SALTAPS on the hip, and in particular in relation to the way that you're going to carry out your assessment. So as I explained earlier, some parts are going to be explained, some parts are going to be demonstrated, but the most important thing to remember is that the subject, in this instance Jodie, is not going to have a particular injury for you to follow, nor are they going to give you any feedback. So you're going to have to describe the way you would proceed through a normal examination procedure. So if Jodie's my subject coming in with an injury, I'm going to describe to my assessors, first of all, exactly what I would do in terms of looking at Jodie when she comes in. I know from perhaps a phone call or something like that she's got a hip injury, so I would look for the obvious signs, just the brief bit of time that I've got to look at her gait as she moves from the door over to the treatment area. So any signs of limping, any sort of pelvic tilt, any changes in gait cycle, any looks of pain or apprehension on her face, any of these things that are going to give me clues as to what might be going on. Okay? So that part of your assessment, as we know, is going to be fairly brief. From there you will move on to taking your history, and what I'd like you to do is make sure that you describe typically the questions that you will ask your client. So again, I would straight away ask Jodie, okay, what sort of injury have you sustained? Where to? When did it happen? How much pain were you going through at the time on a scale of 1 to 10? Has it had any lasting effects in terms of disturbing your sleep, ongoing pain, describing the pain? So is it a dull ache? Is it sharp pain? Is it now occurring on certain activities or movements? Are there any activities or things that you are doing that can alleviate the pain? Okay. If enough time has elapsed, has she had any treatment on it? Is she performing any self-treatment, i.e. taking anti-inflammatories, painkillers, applying ice, having hot baths, anything at all that might influence the way that this injury is progressing? Okay. So typical things that you would put into a history. And again, it's got to be fairly concise because we haven't got time to ask every single question, but just describe the obvious things that you would ask for. Okay. When we get on to the look part of SALTAPS, this is the physical examination stage. So this would be the point where I would stand my client up, assuming she's able to, with this injury, and I would perform some sort of visual static assessment. Now, the level to which you will go will depend on the stage following this injury. So if Jodie said to me, I badly twisted my hip 3 days ago, and she's clearly in some discomfort coming into the room, is there any point in me doing a postural assessment at this stage? Answer, categorically not. Of course she's going to have imbalances. We know that that's directly down to the acute stage of this injury, and therefore what's the point of finding out what those imbalances are at this stage? Later on, as we continue with the treatments, and perhaps 3 weeks down the line when this is nicely repairing, and we're talking about her going back to some level of activity, then we would look in greater detail at posture, pelvic alignment, and so on. Okay? So your visual observations at this stage are going to be limited to the obvious things like discrepancies in muscle bulk from one side of the body to the other, any visual signs of discoloration, again any static imbalances that are quite obvious in terms of pelvic tilt and that sort of thing at this stage. Limb positions, is she externally rotated one side or the other? So the immediate visual things that would relate to the acute stage of an injury. Okay? Any questions so far? Okay, so then you're going to move on to the palpation stage, and for the purpose of your assessment, obviously get your client on the couch. So Jodie, can you lie with your head that end on your back, please? And what we then need you to do is to basically palpate your way around the region that you are assessing. Okay? So go for the obvious bony prominences, and locate them. Be clear about where you're locating them. So first of all, ASIS, you can go straight underneath the sort of elastication of whatever your client is wearing and just feel those bony prominences there. Identify to your assessor exactly what you're palpating. And if you want to, any soft tissues that you're knowledgeable about in relation to that bony prominence. So it may be that you'll say that this is the origin for sartorius. And that just below this is the anterior inferior iliac spine to which rectus femoris attaches as well. You can come round to the lateral aspect and feel for and find the greater trochanter of femur. And again, think about any soft tissues in that region. So quite naturally, with the leg extended and the femur in this position, the iliotibial band should be resting over that greater trochanter. And then anterior to that, you're going to have tensor fascia lata. And posterior, you're going to have your gluteal muscles inserting into that band. Okay? Any other sort of areas that you would palpate around the anterior region? You can certainly come down a little bit and palpate the quads and just identify which of those are lying in what position. So again, you're expressing some knowledge of what you're palpating about. Okay? We can then turn the client over, so if you can turn over onto your front, please. We can continue to palpate and first of all find the sacrum in the middle, identify where the sacrum is and the first of your spinous processes with L5, just palpate your way a little bit up the spine. From there you should be able to work around and just find the posterior superior iliac spine, so the PSIS, and I've got that just under my finger at the moment. And you should feel a little bit of a soft tissue depression between that and the spine. From there, you should be able to track the bony prominence of that iliac crest, forming an arc like that, coming up and round like so. So just make sure, again, that you can palpate those areas. And just remember, your assessor may step in at any stage and actually just confirm what you're palpating. Okay? Soft tissue structures, we've already identified iliotibial band and greater trochanter around here. You might be asked to locate piriformis, so you'd use your bony prominences, the lateral aspect of that iliac crest, your greater trochanter, the middle of the sacrum will form 3 points. You can either form a triangle from between those 3 points and use that midpoint, or imagine where symphysis pubis is. That gives you your rectangle. You can cross like so, and that should locate piriformis for you. Okay? So that's most of your structures palpated, certainly bone-wise, and some of your soft tissue structures. Below the iliac crest, you're going to have glute medius, obviously then glute maximus, and you, of course, can palpate the origins of your hamstring muscles and identify biceps femoris on the lateral aspect, and your 2 medial hamstrings, semimembranosus and tendinosus coming down the medial aspect. Okay? Any questions so far? Okay, so then we're going to move on to our active, passive and strength. So Jodie, can I ask you to stand back up on the floor for me, please? Just remember, we would want all of our active movements done with our client standing, because we are looking for any discrepancies, if you like, or anything that has affected their normal movement patterns. Okay? And you can't get normal movement patterns with somebody lying down. You've got to be standing at this stage. Considering the fact that they may be injured, you may want to offer them support, so we might just bring the couch up a little bit so that Jodie can just support and hold on to that. So if you can turn to face me, just put a hand on there so that you're nice and supported. I guide you through some movements. And the key here is to make sure that these movements are not excessive. So what I mean by this, if I ask somebody to do hip flexion and hip extension, I try and limit to that joint range there. Don't let them do hip flexion hip extension, because that's a lot of hip flexion coming from the other side. Okay? So if you can follow me with these normal movement patterns, your right hip, just bring your knee up as high as you can. Good. Down, and then behind you as far as you can. Okay? Back to standing. So we've done active flexion and extension. We can then get them to do active abduction, and again, as far as the tilt in the pelvis starts, so just to about that point. Good, and back in and across in front of you. Okay. For internal and external rotation, just move that out of the way. We're going to get them to bend the knee, okay, but make sure that the knee stays facing the floor. So we're not going to have the leg sort of waggling around like this. Knee facing the floor like so, flex to 90 degrees. If you now internally rotate by taking your foot outwards, okay, and then externally rotate by bringing your foot inwards. So that's the extent of her active ranges. Okay. Back on the couch, please. Lie on your back first of all. That's fine. Yeah. So you can do basically 3 movements from the supine position and 3 from the prone position. So from here, we're going to do hip flexion to start with. And we're just going to pick the leg up, flex the knee, but keep the knee joint open. So can you put your hands by your side? That's fine, okay. Just so the hands are out of the way. And we're going to take the knee towards the chest like so. You can see how I'm keeping the knee joint open, so I'm not over flexing that joint. Okay. And then back to a neutral position. I can pick the leg up. I'm assuming I can go out far enough without equipment being in the way here. I can check what the full range is for passive abduction, and then I can take the limb across for passive adduction. Remember, with each of these tests, you are trying to find out or elicit any pain or discomfort that may be occurring. And if you recall, with passive movements, if there is any pain or discomfort, it is indicating joint lesion, or joint-related tissue. The only exception to that you may need to be aware of is that when you get to the end of range, you're also potentially stretching musculotendinous tissue as well. Okay? We can, if we want, do strength testing at the same time. So if you're thinking about how many times you're going to turn your client over, we can do those whilst we're in this position. So from here, what I'm going to do is pick Jodie's limb up again. Jodie, what I want you to do is just very slowly at first start pulling your knee towards your chest and build up gradually. Okay. Good. And relax. Down. And now if you can just push your leg out against me. Good. And relax. And then pull in. Good. And relax. So those again are the kind of instructions you're going to give, making sure that the client just builds up very slowly from a light contraction, because there's a potential here for damaged muscle tissue. So you don't want them hurting themselves or being too aggressive with their contraction too quickly. And you're feeling for a nice smooth transition in the contraction. Okay? If there's a juddery feeling to it, or you feel the contraction stop for a second, that's often a sign of inhibition taking place, which is related to an injury. Okay? Would you like to turn over onto your front again for me, please? Okay. People writing furiously, so I'll pause from there. So if we now do extension, what I would do is bend the knee like so, get a hand underneath the thigh so I'm supporting the lower leg, just support the back of the pelvis and that area there so I'm not lifting that too much, and I can do passive extension, and I can see when I reach the end of range, because if I go too far the pelvis will start to anteriorly tilt. Okay? From here, I can also do internal and external rotation passively. And again, I'll watch the pelvis, and you can see when I get to that point, the pelvis starts to rock as well. So that's definitely the end of my passive range that I'm doing. Okay? And then back out in that direction. Now I can do my resisted movements. So from here, Still with the knee flexed, I can put my hand over the hamstrings and ask Jodie, can you just try and push your foot towards the ceiling, please? Good. And relax. And down. One thing about this, don't worry at this stage about trying to isolate muscles. So clearly you've got glutes and hamstrings working together, okay? For the most part, it's glutes working in this instance because the knee is flexed. If you get pain on strength or a resisted movement, then you would explore further to try and isolate where it's coming from. Okay? And then we can add some resistance. So I would put my arm like so. Can you just gently try and pull your leg inwards, like so, and build and relax. And then we can do the same, just pushing out against me. Good. And relax. And with each of those contractions, I'm really not allowing Jodie to get anywhere near 50% of maximal voluntary contraction. We're just testing for injury, not their full strength at this stage. Okay? So that has covered SALTAPS through to special tests. So we'll pause there and allow you to do that. And then I'll bring in all the special tests for another demo, and we'll go through that stage as well. Okay?